discussion with eminent doctors. On the panel discussion today, we are going to be discussing the following topics. How understanding the novel virus first, understanding the symptoms, the testing available, and the treatments that are available as of today, and how much it can treat, while also what you have to do to protect you from coronavirus. We have all heard different solutions for protecting ourselves, including bleach, etc. And we want to clarify some myths today, so clarifying also conspiracies that is going around. The other important factor is we have a doctor from India, as well as one doctor from New York and one from the West Coast. So we want to see how, if at all, there is any geographical effects on COVID. And that's another topic that we want to cover today. And COVID has changed the whole world, and it has also changed the scenario for various medical patients with different treatments. Only recently, in fact, elective surgeries got opened up. Till now, everything was on a halt. So how is it affecting patients around the world? And the various treatments for different diseases. That's another point that we want to cover today. Later on, we'll have a question and answer session. But before we go on to the topics, we have our co-partner, Bharati Tamil Sangam, and we have Sundar here from Bharati Tamil Sangam, who wants to say a few words. Sundar, on to you.
Thank you, Shobha. Vanakkam. Good evening, good morning to everybody. Bharati Tamil Sangam BATS is a non-profit cultural organization for worldwide Tamils adhering to Hindu culture and Dharmic traditions. Now, our mission is to educate and seed the young generation of global Tamils with India's richest cultural heritage, history, spirituality, Tamil arts, literature, along with the richness of our classical language that proudly interconnects all of us globally. Now, we have been extensively involved in a number of community programs, fundraisers to help support the people in need, especially during the emergency situations like the historic Uttarakhand floods, Nepal earthquake, Chennai floods, and many other situations. As we began our 14th year of community service on the Tamil New Year last month, we were right in the midst of this worldwide pandemic, COVID-19, that affected billions, crippling world economy, infecting millions, and taking hundreds and thousands of lives. Our frontline workers have been working 24/7, risking their lives to protect all of us, but we are in serious shortage of protective gears. BATS has taken up a task to make 2,000 secondary masks on urgent basis. More than 30 volunteers came forward and worked tirelessly for the last 1 month, adhering to all the social distancing guidelines, working from home, making this masks. And as of yesterday, we have completed and delivered 2,300 secondary masks, handmade by the volunteers to various institutions, including hospitals, police, assisted living communities for the seniors. In the line with the greatest poet Mahakavi Bharati's words of wisdom, public service is yoga. BATS will continue to actively participate and undertake voluntary social service activities, and will work very closely with like-minded organizations like the CIF. BATS have been working with CIF for the past few years on a number of initiatives, fundraisers, such as Saral, Kitchen Keladi to combat cancer. Our heartfelt thanks to Mr. Kannan and team for having us here and giving us the opportunity to be the community sponsor for the panel discussion on the pandemic. Thank you very much. Vanakkam.
Thank you, Sundar. Now we want to go to our event. I would just like to introduce the doctors before we move on to the event. We have Dr. Ravikannan, who is the director of Cachar Cancer Hospital and Research Center, Silchar. In fact, this hospital, we have cancer patients from various socio-economic backgrounds for free care. And sometimes they are also they are provided with food, accommodation, and other basic needs as well. He had served in various positions at the Cancer Institute before moving to Assam. In fact, his latest stint was as a professor and head of the Department of Surgical Oncology in the Head and Neck Division. Earlier this year in January, we are very proud to say that he was honored with the Padma Shri Award for his contribution to medicine. He helps our Cancer Institute Foundation by providing second opinion to various patients around the world. Let's welcome Dr. Ravikannan. Welcome, sir.
Thank you.
We have Dr. Krishnamurthy Sundaram, who is another panelist today. He is the grandson of the founder of Cancer Institute, Dr. Muthulakshmi Reddy, and is also one of the board of directors for our Cancer Institute Foundation. He is currently serving as a clinical professor of otolaryngology at the SUNY Downstate Health Sciences University in New York. Previously, he had served as the chief of head, neck, and skull-based surgery at Long Island College Hospital as well, at Brooklyn, New York. I'm just naming a few because We don't have time to cover all the various positions he has held in different hospitals, and that's how long the list is. Let's welcome Dr. Sundaram. Welcome, sir.
Thank you. Thanks.
And our third doctor for today is Dr. Sandy Srinivas, who has supported our Cancer Institute Foundation in various events, in various ways. Also, the Adyar Cancer Institute itself, she has helped by providing medicines and other stuff. Dr. Sandy Srinivasan is a professor at Stanford University and specializes in urologic oncology, takes care of patients with prostate, bladder, kidney, and adrenal cancers. She has practiced in this field now for more than 20 years and is the clinical research group leader for the urologic program at Stanford. And her is a principal investigator for numerous trials. She's also the medical director for the inpatient hematology oncology unit. She has received numerous teaching awards and is currently a very well-known recognized expert in the field of urologic oncology. Let's welcome Dr. Sandy Srinivas. Welcome, doctor.
Thank you. Pleasure to be here.
And to moderate our panel discussion with these three eminent doctors, we have Anu Hasan, who is very well known to all of us. She's an anchor, she's a writer, she's an entrepreneur, you name it, she has done it. And in fact, she currently has a series of events with various doctors in her own FB page where she is helping the masses, trying to clarify various questions and doubts by talking to different doctors in various fields as well. And for the Cancer Institute Foundation, she has helped us even before by helping hosting one of our shows. And this is the second time we are having her with us today. Welcome, Anu. Let's welcome Anu Hasan. Thank you.
Thank you.
On to you, Anu. It's all.
Thank you very much. Yeah, thank you very much, Shobha. I think at the outset, all of us who are here, as well as all of us who are watching, one thing we have to acknowledge is that we are very, very grateful for the time being given to us by all three doctors, especially at this time, because this is the time when they are most busy. But this is also the time when their knowledge is so crucial for us, because as I was telling Dr. Sandy at the beginning, before we all started streaming live, there is such a glut of information and such a dearth of validated information. So we're hoping that this session will help clarify and help us segregate what is real information, what is correct, and what are just people's opinions just floating around, which is just not been verified or validated. So let's jump straight into it. We've got a series of questions here. And for the purpose of the people watching, what we're going to do is we're just going to go in a kind of a round robin fashion with the doctors and have one doctor answer it, and then the others add on to whatever they might want to include in for the answer. So Dr. Ravikannan, if I may start with you. So first of all, I think when we want to fight an enemy, we need to understand the enemy. So right now, if we look at COVID as our enemy, we need to understand exactly what is COVID. So we've heard that it's mutating, how many strains there are. It's different from what is in India, what is in Europe, etc. So can you give us a brief overview about this new coronavirus, please?
So COVID belongs to a group of viruses called coronaviruses. These are called corona because of the projections on the surface of the virus, which resembles a crown. And they've been around for a long time. And in fact, most of them are in mammals, in animals, not in human beings. There are 7 strains that are known to affect human beings. 4 are responsible for, common cold-like symptoms for a long time. And 3 of the newer ones, the earliest 3 are the more aggressive variants.
I think we're having some internet issues, Dr. Ravikannan.
COVID-19 is the sorry.
I think it just froze and we couldn't hear anything. I wasn't sure if it was the same issue for everyone. Yes, please carry on. I think...
what I do is I will go...
Okay. So Dr. Ravikannan is dialing in from quite far away, so there might be some internet issues there. Dr. Sandy, if I may pass back this question to you. So we've heard a little bit of what Dr. Ravikannan said. Could you please add to that?
Sure, catching up to what he said. So it is coronavirus is named because it has this crown-like features. Like he said, there are about 7 of these. Most of these cause common cold, and they've been around for a long time. 3 of those are a more severe variety, and we have actually had experience with this class of virus in the past with the Ebola virus, with the MERS, the SARS. And this is a group of virus, we call them zoonotic viruses, which means that they are transmitted to animals, and from animals, the transmission is to humans. So what we know about this new corona novel virus is that it's transmitted probably from bats to humans. So the unique thing about this is that there are multiple variants. You know, as you know, it all started at the in China at Wuhan, and it's now a pandemic affecting almost every country in the world. And there are different strains. You know, there is an L strain and there is an S strain. Molecular footprints are a little bit different, but how they affect different parts of the world is somewhat hard to piece out even now. It's true that the incidence, the mortality, the severity of this virus is different in different parts of the world, but it's a little unclear. I'm sure we'll talk a little bit about different factors in different parts of the world, such as temperature and weather. But for now, we do know that there are different strains, and viruses in general are known to mutate. And this has been an issue with the flu, for instance, which constantly mutates, which is why you need a vaccine every year. You need to make a new vaccine. So as Shobha said in the beginning, I mean, this is all relatively new to us. There's a lot of unknown, and almost every day there are new pieces of information coming on. But I think where we are at now is that definitely there are some differences in strains, and their behavior seems to be a little different in different parts of the world.
Dr. Sundaram, would you like to add to this?
Yes, I don't want to repeat things that were said by the other panelists, but definitely I'd like to say, you know, these are RNA proteins, and therefore they can mutate. And the novel coronavirus is a very aggressive virus, and what it does, it attaches to the ACE2 receptor in the various cells in the body. For example, it can attach to the ACE2 receptor in the lungs, surface of the alveoli, the ACE2 receptor in the kidney tubules, and the ACE2 receptor in the Leydig cells of the testis. That's why there's an increased incidence of men. Men are more susceptible because of the fact that they have the Leydig cells in the testis, and also the vascular endothelium. And when it affects all these cells, it attacks the various organs, and it's able to therefore attack the brain, the liver, the lungs, the kidneys, and then it becomes very lethal once it really attacks all these organs. So the idea is really, the take-home message is prevention at this time with all these factors that we're doing. And we have to remember, as Dr. Ravikannan initially mentioned, these viruses have been there for millions of years. They have lived before humans came, and they are going to survive after. We don't know, how long they will survive, but they're going to survive for a long time. So the trick here is to learn how to live with these viruses, protect ourselves, and coexist with these viruses.
Thank you. Thank you, doctor. So actually, when you said that, I remembered when we were talking to someone, another doctor, he was saying, this virus, that, as all of us have been saying, it's relatively young. It took us 2,000 years. Typhoid has been in existence for several thousand years. So, it'll give you a perspective on how new this virus is. That's what we were told. And so when we know that it is so aggressive and this is how it is, immediately the first question we want to know is, how do I know that I've got it? How do I know that, I have been infected? What are the classical symptoms that I need to look for? So Dr. Ravikannan, is your signal good? Would you like to take?
Yeah. So we may know or we may not know. A large number of us who are infected will never develop symptoms. It will just stay asymptomatic. And so it's just a matter of testing. Out of those who become symptomatic, almost 80% will have very low grade symptoms, just like a common cold, Only about the remaining 15%, 20% will develop serious illness enough to merit admission into an ICU, and less than 5% will need ventilatory support. And common symptoms, if they occur, are, like other flu symptoms, sore throat and fever, and very much similar. There are the people will say, in flu, you will not sneeze in, you will sneeze in COVID infection, you will not sneeze. The symptoms are almost similar, Only thing is with this infection, as Dr. Sundaram mentioned, we could have more serious symptoms related to the brain, to the heart, to blood vessels, to fingers, and but for the most of us, those who become symptomatic, symptoms will be more or less like common cold: body ache, sore throat, fever, headache, malaise, diarrhea.
So that is rather concerning, because immediately then the other question that rises is, if you're asymptomatic, then are you silently transmitting? And therefore it is even more dangerous. So it's almost like the Schrodinger's cat, right? So we don't know whether it is there. If you see it, is it there? Like that. So Dr. Sundaram, how do we deal with the asymptomatic carrier situation?
Well, the asymptomatic carriers, because of the fact that they are very deceptive, we have to use extra tools that technology has helped us with, such as, it's a common phrase, testing, testing, testing. 1,000 people have said this. And also contact tracing. These are the tools we have to use for asymptomatic carriers. And if one of the things that we can find asymptomatic carriers, they might have just had a little sniffle and a sneeze, and they might be carrying the virus. So if everybody could be tested, which is now happening in the New York area, the test is available from yesterday probably, to every person who wants to get a test can get a test. So testing everybody, as much testing as possible, and locating the asymptomatic carriers, locating their contacts, and trying to trace their contacts would be the best way to deal with asymptomatic carriers. The second thing with asymptomatic carriers is universally wearing masks in public. The mask is not to prevent ourselves, to help ourselves, but actually to prevent us spreading the disease. So this way, if an asymptomatic carrier wears a mask, they can, even if they sneeze or they cough, they will prevent it from transmitting to other people. And also everybody has to constantly wash their hands, and be careful not to touch the face. And these are the things that we have to do to try to prevent transmission by asymptomatic carriers.
Right. And also, gathering from what Dr. Ravikannan said and what you are saying, there is no way we can tell whether this is a regular flu or COVID unless we test. Am I correct?
Yes, except that the regular flu, if the person has been immunized against the flu, and their symptoms will be mild and it will go away in a few days. If the temperature starts spiking and it stays more than 3 days, and also if they can get the O2 sat monitor that they can put on their finger, which is available in every pharmacy in the New York City area, then if the oxygen saturation goes below 92%, we are advising them to come to the emergency room and get tested right away.
Right. Which nicely segues into the next one, which is about testing. So, Dr. Sandy, about the testing kits. How reliable are they, and what are the types of tests that are available? Can you, and I've heard about the nasal swab, etc. Can you help us understand this aspect, please?
Before I get there, I just wanted to add a few more points to what has been said so far, just to clarify things. Like was said, I think 80% of the time it's very, very mild illness. It's about 15% where they have severe and 5% have really critical symptoms. In addition to all of the other symptoms that were mentioned, loss of sense of smell has become a criteria that's very unique to the COVID. And some of the difference between the common flu versus COVID is that flu is quite abrupt, whereas for the COVID, the illness seems to be more gradual. It's over a period of time. There's some differences between the incubation period for the flu compared to COVID, which is much longer. So these are some differences. I mean, even for me personally, I have a sore throat and I think, oh my God, do I have the COVID? For most people, I think, it's an illness that just comes and probably will be nothing. But I think it's important to recognize the shortness of breath is something that's more unique, where it gets progressively worse, where patients come into the emergency room with hypoxia and having trouble breathing. You don't commonly see that with the flu. So I think that there are some differences. And to the audience who are listening in, I would say if you have a spiking fever, profound body ache, muscle ache, with shortness of breath, I think that's certainly a criteria that you would need to call your provider and get guidance in terms of testing or seeking medical attention. The one additional thing that I wanted to say was the difference between the flu versus COVID. What's the big deal, right? Why is there so much press about this? There's something about the infectivity about COVID compared to flu. So people in the medical field talk about this R0, which is the rate of infectivity. So if you take something like the flu, the R0 there is 1, which means that you're likely, if you have the flu, you're likely to infect one other person. Compared to COVID-19, they think that the R factor is maybe like 2.5. So for one person who has it, you're likely to infect at least 2.5 times more compared to the common flu. There are other illness like measles, for instance, is highly infective. The R0 for measles is something like 18. So we have dealt with very infectious type of viruses and illness in the past, but this is certainly unique because this is new to us and we are learning about this. So moving on to testing, I think testing, there are at least about 15 or more tests today, and there are 2 types of tests. One detects the virus itself. So do you have the virus in your body or not? And that's the most common test that's used. And today it's done most reliably by a nasopharyngeal swab. So that means that they put a little tube inside your nose, and it doesn't stop at your nose. It actually has to go in deep into the nasopharynx. So it is a little uncomfortable. For those who haven't had the test, it's about 10 seconds of some excruciating discomfort, but it's not impossible to, knowing that it's only 10 seconds, you can get through it well. So the nasopharyngeal swab really detects the virus, and that's today done by PCR. There are many different types of tests, and the reliability varies from one test to the other. The second one is the antibody, which is detected from your blood. And that detects, there are 2 types. There is an IgM antibody and there's an IgG antibody. And what that really tells you is, have you had exposure to the virus and have you mounted an immune response? So the first antibody that comes in is the IgM. And after a period of time, you develop the IgG antibody. So today, both the virus detection as well as the serologic blood test detects the antibody.
Right. But am I correct in understanding that even if we do the antibody testing, we are not very clear whether we have built an immunity to it or whether we are going to have a chance of reinfection? Is this understanding correct?
I think the issue of reinfection, definitely we don't know. So just because somebody has a positive antibody, certainly it means that you've been exposed to the virus and your body has mounted that immune response. So in general, people think that's a good thing. But what we don't want the message to say is just because you have the antibody positive, that doesn't mean you shouldn't take the other precautions such as wearing a mask, social distancing, doing adequate hand washing, not taking your hand to your mouth. All of those are important measures because this is new. Unlike the long history that we have with the flu, we don't have that kind of information with this virus. But I think having the antibody, we feel, definitely means that you've had the exposure. And we'll talk a little bit more about the plasma that people get who have had exposure. But I think you're right. Absolutely, we don't know much about the rate of reinfection. So if I have the antibody, does that mean that I'll never get it again? That remains to be
seen. And where is Stanford with respect to test kits? Would you be able to tell us that?
Sure. I mean, I think Stanford has been really fortunate because we've had one of our own investigator in the lab who developed this test. So very soon, early on, we were able to get our own test and were able to scale it up. That test since then has a pretty good performance with a high sensitivity and specificity. So we've been able to use it not just for our patients initially at Stanford, but for multiple institutions across the Northern California area. We have now, I mean, since things have gotten better, we have moved now from patients to how do we bring healthcare providers to the front line? How do we get patients to come back to feel safe, that it's good to come back to Stanford? So I would say in the last week or so, you know, there've been about 14,000 healthcare providers. So now anybody who's patient facing undergoes the test, including myself. I've had the test, and fortunately our positive rate among healthcare providers has been extremely low. So with 14,000 people tested, the positivity rate is like 0.4%. So that's really good that we know that there's not much spread among the healthcare providers. Our next phase of testing is really doing it for asymptomatic patients. And in the cancer world that we are in, this becomes very relevant. So currently we are testing all patients who undergo surgery, all patients who are going to get radiation treatments, all patients, especially surgical procedures which have head and neck and high risk features. And we are also extending this asymptomatic testing to patients who are undergoing chemotherapy and immunotherapy, and also to patients who are greater than 60. So I think ideally, once we have enough number of kits, it should be for everybody. And clearly there should be repeat testing as well. But for now, we are just starting off in the first phase with these high-risk patient profiles.
Right. And Dr. Sundaram, it has been particularly worrying and intense in New York. And also, so is there anything you'd like to add to the testing scenario, considering this situation in New York area?
Yes. One of the things to understand about testing is that the nasopharyngeal swab is probably the highest percentage of reliable, as Dr. Srinivas mentioned, because it's done at the first time. But all the other tests, you know, for example, you have multiplicity of tests. They become negative with the passage of time. The nasopharyngeal swab, you will most probably be positive around 2 weeks. And then you do a saliva test that's more positive around 3 weeks after infection. And then the stool test, sometimes the nasopharyngeal swab is negative, and then you test the stool test is positive till about 6 weeks. And then you do the antibody test. And even in the antibody test, the IgM is positive around 6 weeks, and then it becomes negative, and then the IgG becomes negative after about 8 or 10 weeks. For example, I had the antibody test because I felt I had symptoms and I was exposed to a lot of the corona patients. and I was tested negative. So that kind of surprised me. And I find that a lot of my colleagues also have the same experience. They all feel they had symptoms. Some of them tested positive and some of them tested negative. I also am the division chief of ENT at the Brooklyn division of the New York Presbyterian. So I'm also exposed to the Presbyterian experience. And they have testing available for all patients. As Dr. Srinivas said, when the patient comes in, especially for our head and neck procedures, they have, but we are not doing elective procedures right now. We are still only allowed by the governor to do only semi-urgent, urgent, and emergent procedures.
Right.
So because of that, they are able to test everybody. All healthcare workers are allowed to be tested. Initially, they had criteria for testing healthcare workers. Now, anybody who wants to test can have a test. And as far as the PCR nasopharyngeal swab, any patient or anybody who wants to have the test in New York State can now have the test. So tests are freely available. But also, as Stanford has made their own test, the antibody test is also made by Presbyterian. But then it says it's not FDA approved. You know, many of these are approved by their own university systems, but not approved by FDA. So I don't think these tests are 100% standardized throughout the country, but I may be wrong. So there's only so much you can rely upon testing.
And also considering, again, which brings us back to the fact that this is so new and we ourselves are learning so much about this. So it is only natural that we are at this stage when it comes to the testing and testing kits. Dr. Ravikannan, how is the scenario in India? How different is it or how similar is it when it comes to testing?
So just to add a little bit, the PCR testing that detects the viral protein, in the initial 2, 3, 4, 5 days, it will be negative. So as Dr. Sandy said, retesting is very important. A negative test that in an asymptomatic individual will not tell you whether the individual is truly negative or he's in the initial phase where the test will not show up the virus. Same way when we test for antibodies, when we test for the IgM, it suggests infection. But if IgG is positive, we don't know whether he or she has cleared the, and they appear much later, So tests all have limitations. No test is really foolproof. India is started much later, and India is a vast country. Different areas have different, what is happening in Chennai is not happening in the Northeast. Even in the last Spanish flu, the Northeast caught up much, much later. And so different states have different scenarios, and so.
And also huge challenges, isn't it?
Yes.
Right. And
one point for the audience to touch upon what Dr. Ravikannan said.
Testing kits are not as universally available.
I think, if somebody is tested negative, the message I want to say is if you have symptoms such as whatever that's been listed for corona and you test negative, I would assume that you actually have the virus and use all the universal precautions, masking, self-isolation, good hand washing. The tests are not, the timing, as you can tell from the panel, that tests could be negative. It depends on what time of your illness the test is being done, the sensitivity and specificity of the test. So tests are not completely reliable. If you have your symptoms, assume that you have the illness. And the most important thing is self-isolation and quarantine.
Right. And we cannot stress that enough. The self-isolation and quarantine and all the social distancing and other practices that we've been urged to follow. Yes, and then there comes a question of remdesivir, hydroxychloroquine, and blood plasma as treatment options. So I would throw it open to all three of you, whoever would like to give us a brief outline of these treatment options, please.
Well, I'm happy to start, I would just start off by saying that there is no treatment for COVID-19 today. Everything is experimental. There are some that hold promise, and I think it's going to be a while before we really figure out what's the optimum treatment. What has been tested to date is the anti-malarial. So there was a lot of press about chloroquine and hydroxychloroquine, and then combining it with azithromycin. The bottom line is that that wasn't very helpful. So I don't think chloroquines, there have been some controversial data, so I don't think chloroquines is recommended by the CDC today. The one that has been held some promise is remdesivir. Again, it's an antiviral drug. There have been, again, conflicting trials. There's been a 1,500 patient trial that shows compared to placebo, this drug decreases your recovery time, from 15 days to 11 days. So it's not that it's making people live longer. Most of us in medicine, when we say that the drug is effective, it's based on large randomized trials. It needs to prove longevity. So is a drug successful just because it shows a decrease in recovery time? I think it has some promise, but it's not the cure-all. So the search continues. So that's the story about remdesivir. There is a lot of other drugs which are on the pipeline, just like HIV. So one of the things is because it's a virus, people have gone back to taking existing drugs and trying to see if we can repurpose it. So one promise is with the HIV drugs. So the way we combated HIV is not with one drug. It was really a cocktail. So there's some trials looking at, again, multiple drugs in this scenario, trying to fight the coronavirus. Some other areas of promise is that this is really, in some ways, the flu is your body creates an immune storm. That's what happens, right? When you have the fever and the flu, there's a variety of immune dysregulation that happens in your body. So we have a lot of drugs in the rheumatology field that we use today to suppress this immune flare. And some of those drugs are being used in corona today. So there are multiple interleukin-6 inhibitors, interleukin-1 inhibitors. So these are all in clinical trials and appear to have some promise. But the bottom line is, unfortunately, I wish I could tell you we have a treatment. We don't. And these are all mostly for people who are severely ill and who are in the hospital. Many of drugs are in trials looking at high-risk patient population. So could healthcare providers take something prophylactically in a preventive fashion? We don't have any, but all of these drugs are in current clinical trials addressing some of those questions.
Right. Dr. Sundaram, and considering how rampant it has been in New York, plasma therapy, as they call it, has that given some hope? And also, if we've received a question that says, if I tested antibody positive, then can I also be a plasma donor? So can you help us understand this bit, please?
Antibody positive people, if they have no other illnesses and eligible, for example, to give blood transfusion, can also become plasma donors. And but they're all only trials. They're all in the trial phase. Plasma trials are going on at all institutions within the guidelines of protocols, and we're still awaiting the results of these plasma trials. The other thing, of course, is that I think remdesivir is the only one that's FDA approved for emergency use. I don't know, Dr. Srinivas, am I right, or am I making a mistake?
No, you're right.
Yeah. So, but other properties are as you described, but FDA has approved, rather than just in the context of a trial, any hospital can use remdesivir as an emergent medication for, especially for ICU.
Right.
For the critically ill patients.
Yes.
Right. And vaccines, are we at a stage where there is hope, or we still have a long way to go?
We don't know, because there's so much coming out on vaccines. Yesterday, I saw President Trump's new vaccine czar come out and insist that the vaccine is going to be available by December. So we have to really wait and see. But Johnson & Johnson has the vaccine. There's a Dutch vaccine that has been shown to actually reduce the viruses. And they are trying to now change it to human trials. And there are also German vaccines. So there's lots of vaccines coming up. And we have to wait and see what the final results will show.
Right. Dr. Sandy, is there anything you'd like to add to the vaccine subject?
I think I agree that there are probably about 15 vaccine candidates. You know, there are 6 in phase 1 right now. I mean, as you can imagine, you know, for the flu vaccine and truly in a testing, for a vaccine to start, you start it in animals and then you put it on to humans. It has to go through a safety first, and then there is efficacy. So a typical vaccine from start to getting into humans for it to be used in everyday practice typically takes years. Clearly here we are all in an overactive mode to try to get to something as soon as possible. I know Pfizer has a vaccine that is in humans right now, and they may be going to phase 2 sometime in June, and are hoping that by September, October, they might get more safety information. So we are all fingers crossed maybe for something by fall, but it's up and down, you know, and many of the, as far as we go at Stanford, there are many cancer vaccines, you know, people working in the lab who are all working towards cancer vaccines have all switched their approach in trying to find a vaccine for the COVID-19. So there's tremendous preclinical effort that's being taken on, but vaccine is a challenge. You have to find one and then you have to scale it up to have enough production to cover the entire population. So that by itself is another challenge.
Yes, there was one post put out by the WHO which said we have to find the vaccine, then we have to test it, then we have to produce it, then we have to reach it to the people, and then the people will want to have to take it. So there are challenges at every stage that we are going to face. That's what we said. But Dr. Ravikannan, then this is something I wanted to ask you. The BCG vaccine. So I've been told by quite a few people that, oh, you've had the BCG vaccine and a lot of people have had the BCG vaccine and that is going to give us immunity. Is there any truth in this kind of a thought process? Or have we any proof?
So we don't know. That is the answer. See, the thing is, India did not develop the number of cases with the rapidity with which many other countries developed. And the criticism was India was not testing enough. True, India was not testing, but the fact also is we may not test and identify patients, but the hospitals are not really filled with patients with pneumonia. The ICUs are not overloaded with sick patients. So something is obviously different in India, Pakistan, Bangladesh, which is different from developed countries. And then now that we are identifying so many more patients, but the death rates don't match up. We're not seeing so many patients dying, you know. You can hide pneumonias, you can hide testing, but you cannot hide deaths. And so clearly something is happening in less developed countries when compared to more developed countries, whether it is BCG or malaria, or we really don't know. We have yet to learn to figure out what is happening. It's quite possible we may catch up with the developed countries, you know. We don't know. Only time will tell us what will happen. But as of now, there is no evidence to say BCG protects. Though India is looking at the BCG vaccine, you know, but there's no evidence to say that.
Yeah, it's a very interesting concept because it came out from a retrospective observation where they looked at countries that had BCG as part of their
Vaccination program.
Vaccination process, right? So they looked at countries that had BCG as part of this versus developed countries where TB is not a big problem in countries like the United States, right? So what they found in this large group was there was a 10-fold decrease in the incidence of COVID-19 in the countries that had BCG vaccination as part of their immunization compared to those who don't, and the death was less. But clearly these have inherent problems, right? BCG is just one of the factors. So like Dr. Ravikannan said, you can't just hang your hat and say that BCG is completely protective. Since then, there have been a lot of studies that have also come out saying that just because you have BCG in your childhood, that's not completely protective for you to not get COVID when you, as an adult. So there's a lot of work to be done, but there are again clinical trials. BCG is not that hard. It's been around for a long, long time. It's very safe. We know about the efficacy of BCG for a long time. So there are trials now looking at BCG vaccination in healthcare providers to see if that would actually be prevented. So I think it's a very interesting observation. We just have to wait for more information to come out as to how effective it is.
Yeah.
Right. Yes, Dr. Sundaram.
Yes, can I add something? I was very happy when I heard about the BCG vaccine because I received BCG in India as a child. But I just, last 2 days, I saw a study that came from England where they took two groups. One group was the people in England who, I think it was in JAMA or Lancet, it came out. One group was people in England who never received the BCG vaccine. And the other group was immigrants who immigrated to England who received the BCG vaccine. And they found there was no difference in the incidence of COVID-19 in both groups. There was no reduction in deaths. There was no reduction in ICU hospitalization. So there's really no difference whether you received the BCG or not. That's another myth that is, I think, probably looks like it's not going to hold up.
So that's my hope dashed. So it's not going to be BCG, the magic. Yeah. But the other thing that also people are propagating, especially in India, Dr. Ravikannan, they are talking about Siddha remedies and they're talking about homeopathy. They're also talking about arsenic 30, I believe. I don't know. What are your thoughts on that?
No evidence at all and should not be propagated.
Yes. It's as simple as that.
Only thing we must propagate is universal precautions. We know what is causing it. We know we don't have a foolproof remedy. We know alternate forms of treatment don't help. So the only thing that we must all push aggressively is universal precautions and of course access to testing.
Right. Very succinctly put. Thank you, Dr. Ravikannan. And one more question specifically for you, Dr. Sundaram, that I have here on this list is, why was New York affected so much? I mean, is there something that was pointing to it, or is it something that's mysterious?
No, it's a very simple fact. New York is the hub, one of the hubs of the world. And there's so many flights coming from Asia, Europe, Middle East, and everybody was carrying the coronavirus and bringing them here. China, they blocked the flights from China or they restricted the flights from China end of January. The virus was already out by November, December in Wuhan. And people were flying to Europe. And then from end of January to the middle of March, till they stopped the flights from Europe, everybody was coming from Europe, Italy, and the Italian virus was very bad. And they brought all these viruses from Italy and everybody got very sick. And one of the other things that also happened is that England, they never stopped the flights from England till the last minute, till Boris Johnson got sick, and then they stopped the flights from England. So they were also bringing all these viruses here. And also New York City is a very highly populated city. And actually Brooklyn in those days, which is a month or 2 months ago, was the epicenter of the epicenter in the United States. And that's because of the crowded, apartment living. the number of nursing homes which had elderly people and the virus just, the people who worked there just brought the virus from outside and gave it to the nursing home residents, and many of them died. And also the group homes. There are a lot of disabled people living in group homes. They all got affected. They all passed away. So this is reason why New York City was bad. And in fact, I have some figures that I can give you. In New York State, there were over 1.3 million tests that have been done. And there were 345,000 cases of the virus in New York State. And over 6,000 people have been hospitalized, and 2,700 people were in ICU, and there are 22,000 deaths in New York State. And the United States has 87,000 deaths. So this is almost like 1/6 of the deaths in the US. So it was bad, and it's still a little bad. It's not back to normal. Upstate New York, they're open for elective surgery. New York City, we are still not able to do any elective cases.
Right, right. And Dr. Sandy, when patients get on ventilators, there's another, I'm moving to another question that is here. I have seen the time, we have about 5 or 10 minutes left. So I'm just having to be selective about some of the questions, I'm afraid. So one of the things that people are worried about is that COVID patients are dying because of ventilators. Is this a true information that we're getting?
I mean, I don't think that's necessarily true. We have learned over this many weeks now that our threshold to put people on the ventilator has changed as well. You know, when this first started, anytime somebody has their oxygen saturation drop less than 90% and they have this X-ray that looks really concerning for fluid buildup in the lung, what they call as ARDS, people were very alarmed and they would connect them to a ventilator. In general, people who are on the ventilator, if you're not on it just for one day, you're typically on it for a week or two before your lungs get better. So inevitably what happens is that they end up having other infection just because they're on the ventilator. All the ventilator does is it's giving them that amount of oxygen that they need to allow their lungs to rest. I don't think the truth is that people are dying because of ventilators. I think people who need a ventilator are sick enough that they are dying because of their illness and not specifically from the ventilator. Things have turned out that people don't intubate that rapidly. People are willing to wait. You know, you can live with an oxygen saturation that's low because even though they have an O2 saturation of 70%, people are having a conversation. They are able to speak normally. So, and then you can put them in their face. So it's called the prone position and they're able to breathe better. So our threshold to put people on the ventilator has changed quite a bit in the last several weeks.
Right, right. And following up on what Dr. Sundaram said, there is a question from the audience, Dr. Kannan. They are saying that, okay, so New York was affected so badly because there's so many flights landing in. Could it be that India is not affected so much because we don't have that much international travel?
So what's happening in Mumbai is a miniature replica of what happened in New York. See, why does Mumbai and Chennai and Ahmedabad and Delhi have all the larger number of people? Because these are commercial hubs, you know, where flights come, people land, and that's what is happening here as well. Why is it that in the Northeast we don't? Because people don't travel. It's ultimately community transfers because through people to people, and people don't travel to the Northeast so often. So the Northeast is sort of relatively isolated. So that's what is happening.
Right, right. And there is also a follow-up question from the audience. I'll leave it open to you. Earlier, we were under the impression that children are not really being affected by COVID. Is there new cause for concern with COVID-19 that children are indeed more vulnerable now?
Well, I'm happy to add a comment that we are in the beginning for sure, you know, children seem to be less affected by this compared to adults. There's some new information that kids are being admitted with an illness that seems to be very similar to what we have known in the past called the Kawasaki illness. But again, I think it is kids who have underlying medical problems, that's very similar to adults. Most of the patients who are having a hard time and where there are fatalities are those who have underlying medical problems. So including in kids, the ones that we have seen to date are children who have underlying medical problems. I would say that the concern is less for kids compared to what we know about adults. But certainly if somebody has fever, runny nose, conjunctivitis, lymph nodes that are enlarged, parents should be seeking medical attention.
To go
Is there
back to your
anything?
first question, sorry.
Yeah, that's what I was.
Influenza is actually spread through kids. COVID is not spread through kids. COVID is actually spread through adults.
Is it?
Yeah.
Could it
Influenza affects kids more. And
more?
kids are actually one of the groups that actually help spread influenza in the community.
Right.
The reverse is with COVID, it affects adults predominantly, as Dr. Sandy said.
Yeah.
Right.
We
Yes.
had 3 deaths in New York from children. 3 children died
Those
in
are
New York.
immune storms, no?
Yes.
After the COVID settles, they have a
immune storm, yeah. And we lost 3 children have died so far, and people are very, very nervous here, and they're very careful about the children. Even though there's no transmission of COVID through breast milk in pregnant women, the COVID, if the mother has COVID, she can give it to the child by the way they're handling the child, or
Yes.
the caregivers can give the child COVID. And if there's COVID during pregnancy, then they can have some defects and so on. So pregnant women have to be very careful.
Careful. So we've almost come to the end, and I do believe that we have not really exhausted everything. So I wonder if it might be a good idea if I gave some time to each of you to add what you think we have missed out. So Dr. Ravikannan, can we start with you if there is anything specific that we have missed out, whether in prevention or myths or anything at all?
No, I just want to re-emphasize, we know what causes the infection. We know how it spreads. We know we don't have effective remedies at the moment. We know vaccines are on the horizon, but we don't know whether they will become a reality, whether they will be adequate immunity, and whether they will be effective immunity. But what we know is prevention can, help contain the pandemic to a very large extent. We must protect ourselves and we must protect others around us. So masking, hand washing, social distancing, these will become new norms, at least for the next few months or a year or so. And that should be our overwhelming message to everybody who's tuned in, that please practice universal precautions.
Yes.
Everything else we are learning. Now, what we are speaking today may change, in the next couple of months. But these things, this will not change. And so this is what we should emphasize.
Right. Dr. Sandy?
My message is going to be related more to our cancer patients. We have done remarkably well in the last decade about the progress in cancer. And our heart goes out to our cancer patients who now, in addition to this, have to deal with the fear of corona and COVID. I would say that as things are getting better, it's all about risk benefit. Don't be afraid to seek medical attention. You cannot delay your chemotherapy. You cannot delay a surgery if it's going to result in a cure. We cannot afford to go back on the progress that we have made in cancer. So I would definitely, my message would be, it's about risk and benefits. In areas where it's safe, we have to move forward with taking care of our cancer patients as well.
Thank you, Dr. Sandy. Dr. Sundaram?
Yes, the thing that I would like to stress, in addition to what has been already said by the other 2 participants, which is excellent, is that we have to think of our personal selves. There's a lot of emotional toll that's being taken because of loss of jobs, no work, economic situations, financial stress, and loss of socialization in many people. this is a time that I think we have to turn to something higher than ourselves, and we have to look at our spiritual strength. We have to listen to our spiritual teachers, and so that we can be helped by this to get through this, and we can face this invisible enemy and overcome it. So my suggestion, in addition to everything that has been said, is to strengthen oneself spiritually along with everything else.
Right, beautifully put. But I do have one more point that I need from you, Dr. Sundaram, because Adyar Cancer Institute has been affected by this. So can you shed some light on how we can help Adyar Cancer Institute and what needs to be done? How has it been affected?
I only know secondhand from what I've speak. So Dr. Shanta probably is the one who really can give more information about this. But definitely, I think financial help is something that is universal that can help them so that they have no problem with payroll and so on. And also the patients are calling because they're very anxious about the cancer treatment. But the institute has to follow the laws that of the lockdown that the government has established. So the patients also, I know it's very hard that they have to be a little patient, but I think the institute will open and do the best it can as long as it's within the limits of what the government allows.
Right. And Dr. Ravikannan, about Cachar Cancer Hospital and Research Center as well. Is there something you'd like to add?
So we have been fortunate that we don't have the pandemic the way it has been seen in other parts of the country as yet. And so we have continued to work. Patients have found it a tremendous challenge to come because of the lockdown. There is no transport. But we have not stopped any part of cancer care, whether it was chemotherapy, radiation, surgery, palliative care. But then the community is in trouble. And so, the resources to pay for treatment, to pay for travel, all these are a major challenge, And that's what is going to happen all over, I guess. What's happening in Chennai will happen here as well.
Yes, yes. These are hard times, and well, apart from the precautions, we also have to brace ourselves, isn't
but
it?
the thing is, we should not be afraid. I think one of the overwhelming sentiments in community is fear. And fear will make us irrational. We'll make wrong decisions. We'll make decisions which are not compassionate, to our own fellow human beings. And that is something we should avoid. We should not become fearful. Ultimately, a large number of us will get infected. That is how we'll develop herd immunity. Some of us will die in the bargain. But it cannot be prevented. And there's no point living life with fear. That I think fear will make us inhuman, and that is something we should avoid at all costs.
Yes, because when we are talking about, fighting a pandemic, we are not just talking about the medical stuff, but also the mental, spiritual, emotional, everything comes together. So I think it's a wonderful message that we've got from all three of you. We've got some facts. We've got some understanding of the virus. We've understood where we are, what we know, and we also know what we don't know. And of course, it is such a vast subject. We had allocated an hour. We are now about a little over an hour. And we still haven't covered it. I'm getting a message saying, but we haven't covered about food, transmission during food. So can we just take 2 minutes to answer that question before we wind up, please?
Food,
Dr. Sundaram?
Virus doesn't needs living objects to thrive, And so virus does not live on food and so food does not transmit, especially cooked food does not transmit virus.
The other thing is...
Sorry?
No, go ahead, Ravi. Go ahead.
No, sir, go ahead.
No, the other thing is when they go to buy vegetables and things like that in the market, make sure that you social distancing, wear the mask, spend as little time as possible in your shopping, come back, wash all the vegetables clearly, wash your hands, and cook all the food that you can, because cooking will kill the virus. And this way, I think we have to protect ourselves.
Dispose the plastic covers safely.
Correct.
Oh, yes. Oh, yes. Is there anything else, Dr. Sandy?
Agree.
Okay. So great. Thank you very much to all three of you. We've had such an engaging and also a very exhaustive set of information that we could not cover in this time. And like I said in the beginning, we are truly grateful to all the people in the who are in the frontline workers and doctors. We are really grateful and for the medical community, because your contribution is invaluable. So first of all, thank you very much for that, and thank you also for your time, and thank you Cancer Institute for Foundation for having organized this. Thank you very much. Shobha, is there anything you'd like to add?
No, again, thank you everyone, and thank you Anu for helping us moderate this panel discussion. Before we leave the meeting, I just want to say from Adyar Cancer Institute, we've always wanted to bring awareness to the community with regards to cancer, but we wanted to use this opportunity to bring COVID awareness. And as Dr. Sundaram mentioned, the institute is suffering to some extent. So whoever is watching this video right now, for the audience, we all need to help our frontline workers in some way or the other. And there are a lot of people hurting. And especially as Dr. Sandy mentioned, specifically for cancer patients as well. So they are hurting, they're not able to get treatments because there's not much funding. So I would like to use this opportunity to request philanthropists and people generous like you to think about funding for any institution you might want, and also the Adyar Cancer Institute. Before we leave, Kannan, who is the president for Cancer Institute Foundation, would like to say a few words. Thank you note. Kannan?
Yeah. Can you hear me?
Yes, we can hear you. Please go on.
That is good. I don't need a video. That's fine. I don't need a video. Thank you very much. I would like to thank Dr. Ravikannan. Would like to thank Dr. Sundaram. Also would like to thank Dr. Sandy and also Hasan. All these four people are already helped Cancer Institute Foundation, and they are also helping periodically. I spoke to Dr. Shanta a couple of weeks ago, actually. So what she told me is nowadays the drugs are expensive, and all the frontline workers, they are afraid to come. And also the transportation is limited in Chennai. So they are treating the in-house patient, so they need the cleaning team actually. So they are bringing the team from outside. It was very difficult. It is very difficult right now. So that's what I heard from Dr. Shanta. And I also spoke to Dr. Ravikannan a couple of weeks ago about the financial activities in Cachar cancer. And Dr. Ravikannan has some reserves, 3 or 4 months of reserves of money actually. So I think he's adapting, like there's a percentage of salary cut starting from next month. And then after that, there is a ceiling. Whoever gets more than 10,000 or something like that, they're going to seal it. And then if it continues again, they're going to cut only up to 5,000. You know, everyone is all across the board. Everyone will get the 5,000 because you need at least 5,000 rupees to live, to buy groceries and everything. No luxury. So I think he's doing a very challenging job in Assam actually. So these people are here. The institution is helping each other actually. CIF is playing a major role. I want to tell one incident. Dr. Sandy, once upon a time, and also periodically she helps. So they sent a set of team to Africa and all the some of the countries in Africa. So they used all the medical instruments. So when they returned back, they brought it back, lots of instruments, and Stanford cannot use it. So Dr. Sandy is kind enough. She gave all that unused instrument to us, and then we send it to Dr. Ravikannan. You know, he's using it. So, so Dr. Sandy also visited last month to Cancer Institute, for a conference. They are very closely working with the Cancer Institute. So these institutions are helping each other very closely. And I want to, Dr. Ravikannan is facing a very, very challenging job. I want to mention that. I think he deserved more than Padma Shri actually. So it's really a very challenging job because I know personally, I went there. It's a really very challenging job. He's doing it. So thank you so much. So I hope audience are getting all that enough information as of today. So from the eminent doctors, thank you very much. Good morning in India and good night in US. Thank you so much.
Thank you.
Thank you.
Thank you.
Once again,
Thank you.
I forgot to thank Bharati Tamil Sangam. So thank you, Bharati Tamil Sangam, for helping us all the time. And they are the local partner. Thank you so much.
Thank you.
Thank you. And thank you very much. Bye, everyone.
Bye.
Everyone,
Bye.
with that we end the event. Yeah, thanks.
Thank you. Stay safe. Thank you.